Hello all, this is Dr. Bhagyesh PORE, Orbit and Oculoplasty Surgeon, Indore. Tearing or epiphora is a very common complaint we hear from our patients who attend general ophthalmic OPD. For ruling out hyperlacrimation, we give them refractive error correction, we treat allergic conjunctivitis like condition, we see for any foreign body in the conjunctival cul-de-sac. If we don't get anything cause regarding hyperlacrimation, we move our attention towards lacrimal drainage passage. We used to assess lid laxity. We assess puncta for stenosis or fibrosis of the punctum. We take the use of syringing irrigation test of lacrimal passage to confirm the patency of lacrimal apparatus. After checking all these parameters, we rest our diagnosis that this is a non-intractable epiphora. So today I will be highlighting in such a young patients in which we usually get patent syringing but they present with epiphora. So I am pointing your attention toward the very routine, very rarely found entity which is known as Centurion syndrome. Centurion syndrome is very easy to diagnose facial deformity which is characterized by high nasal bridge. Because of high nasal bridge, patient usually gets their medial palpebral ligament which is placed anteriorly than their routine position. Because of anterior placement of the medial canthal ligament, whole lacrimal apparatus gets shifted anteriorly so that there will be a big lacus lacrimalis, that is a big gap between the eyeball and the lacrimal apparatus. So even in spite of patency, clear patency of the lacrimal apparatus, the tear secretions cannot go into the lacrimal canaliculus. The second characteristic thing of the Centurion syndrome is punctal stenosis. Because of constant eversion of the lower lid and constant environmental exposure, punctum is always stenosed. And the third important characteristic, whenever you do syringing in such a young individuals, it always be patent. The fourth characteristic is the Centurion syndrome is always a bilateral condition that can be asymmetrical, but it is always a bilateral condition. So friends, let's have a step-by-step surgical video for correction of Centurion syndrome. Principle of repair is to posterior placement of medial palpebral ligament by V-shape incision at the medial canthus and inversion of the punctum which is achieved by diamond excision of conjunctiva and closure of the defect. That will create a good correction of Centurion syndrome. V-shape incision is being given, of course preserving the canaliculi. The soft tissue dissection is done with the help of radiofrequency probe. The medial canthal ligament is being disinserted. The canthal ligament is being refixed to the periosteum of the medial orbital wall posteriorly from its original position. This will create a redundant excess part of medial canthal ligament which we can see in the figure. This redundant excess part of medial canthal ligament will be of no use and hence it is excised. This is the final outcome after the fixation of medial canthus posteriorly. We can see the approximation of the lid with the globe. For inversion of the punctum, we have to excise a soft tissue segment, that is conjunctiva and tenon segment from lower conjunctiva in the lower lid. A diamond shaped piece is excised and we have to close it in a linear horizontal fashion. As soon as we close this defect, we will get a strong inversion of the lower punctum. This is a diamond shaped defect. 60 polyglycolic suture, that is Vicryl suture, is used to cover the defect with a continuous interlocking fashion. To avoid rubbing of the suture on ocular surface, we can take out the suture from the skin side also. The skin incision is closed layer by layer with the help of 60 Vicryl, and this is the final outcome, giving the better cosmesis and relief from epiphora. After 2 months, patient is having completely relieved of epiphora, and such a simple step we can give a better outcome to the patient of Centurion syndrome. Thank you for the